Okay, good day. I am Dr. Mayen Amor. I will again be the lecturer of your renal diseases in children, part 2. So let's start. Before I will start, let us recap on the things that I have talked about last time. So the first part of the renal diseases in children. So again, I would like to review the anatomy of your kidneys. So the anatomy of your urinary tract is divided into two. The first part is the upper urinary tract, wherein it involves everything about the kidney, the upper kidneys. So it is in the glomeruli, the tubules, interstitium, and the vascular compartment. Okay, so this part. And then the other part of the anatomy of the urinary tract is in the lower urinary tract. This includes from the renal pelvis, the ureters, urinary bladder up to the urethra. So we really have to know the basics of your urinary tract for us to identify, for us to understand the signs and symptoms of certain diseases, and for us to know what is the reason behind of such signs and symptoms. So the overall function of the urinary tract system is to filter approximately 200 liters of fluid every day from your renal blood, which allows the toxins, the metabolic waste products, and excess ions to be excreted while keeping essential substances in the blood. So therefore, the main function of your kidneys is for filtering. Other function of your kidney is for homeostasis, like the acid-base balance and the balance of the water salt in your blood. So we will now proceed to the common manifestations of your urinary tract. Usually, you have to identify where is the problem. Is it in the upper or in the lower urinary tract? So if the problem is in the upper urinary tract, so we need to identify what are the anatomy of the upper urinary tract. As I've mentioned, it includes glomeruli, the tubules, the interstitium, the vascular compartment. So, signs and symptoms includes oligoanuria. That means no or minimal urine output, because we have mentioned that the function of your kidneys is for filtering. So, the kidneys will not filter so much fluids, then the urine will be minimal. And then because these water are being retained, that would cause edema to your patient, and also bleeding of your urinary tract in the upper part, causing hematuria. Another symptom, if your problem is in the upper urinary tract, is hypertension. So we need to recall that the juxtaglomerular cells in your kidneys, um, or in this area, is in the upper urinary tract, right? Remember? So the juxtaglomerular cells in the kidneys will synthesize, store, and secrete the enzyme renin. Can you still remember that? That plays a critical role in the renin-angiotensin system, and thus in autoregulation of your kidneys. Hence, if there is problem in this part, there will be elevation of your blood pressure. The other area is in the lower urinary tract. So I hope you can still remember the anatomy of the lower urinary tract. This includes the renal pelvis, the ureters, urinary bladder, and the urethra. So therefore, the manifestations, if the diseases comes from this part, is dysuria, or the painful urination, frequency, or the need to urinate many times during the day, even if you don't want to urinate, but you go frequently to the restroom. Incontinence is the involuntary leakage of urine. So this means that a person will urinate when they do not want to. Enuresis, on the other hand, is bedwetting. So for those of you who are still bedwetting, so please consult a urologist or a neurologist. Lastly, the urethral discharge. So I have talked about the glomerular disorders in the first part of my lecture. So this time, we'll proceed to the second part of the lecture. It includes the urinary tract disorder. So first off, I will be talking about urinary tract infection. So this is in chapter 553 of Nelson's book, 21st edition. So the prevalence of urinary tract, usually the first year of life, the males predominate. Mostly, it is males that will have urinary tract. Most probably, the bacteria is will come to their um, uncircumcised penis, wherein the prepuce is closely in contact to the urinary tract. Hence, the bacteria would stay at that area. But after 1 year old, beyond 1 to 2 years old, the female will now predominate most of the cases of urinary tract infection. So what are the etiology? What are the causes of this urinary tract infection? Primarily, they are from your intestines. These are colonic bacteria. So this includes E. coli, Klebsiella, Proteus, and Enterococcus. There are three forms of your UTI or urinary tract infection. This includes pyelonephritis, cystitis, and asymptomatic bacteriuria. So if you have identified already what part is involved in the infection, your diagnosis of urinary tract infection is a broad diagnosis. That means you still do not know where is the infection located, what part of the urinary tract is involved. But later, if you have identified what part of your urinary tract is infected, then the most specific diagnosis is pyelonephritis, cystitis, or asymptomatic bacteriuria. So what are these? Clinical pyelonephritis, this includes the involvement or when the bacteria have reached the upper urinary tract. Since it have reached or if it had climbed up to the kidneys already, to the upper urinary tract, this will eventually cause renal scarring and damage of your kidneys. This clinical pyelonephritis would manifest as abdominal back or flank pains. Of course, they have reached onto the upper urinary tract. There would be fever, malaise, nausea, vomiting, and diarrhea. However, if urinary tract involves newborns or little toddlers, then symptoms most probably is non-specific. So they can be decreased sucking or no sucking at all. They can be weakness, generalized weakness, etc., etc. But they are non-specific. Cystitis, on the other hand, involves the bladder. Okay, so the bacteria would colonize up to the bladder only, but did not reach into the to the upper urinary tract. So symptoms at this part includes dysuria, urgency, frequency, suprapubic pain, incontinence, and malodorous urine. Since they will involve only onto the lower urinary tract area only, usually these infection will not cause fever and they will not cause renal injury later on, except if this cystitis will progress and bacteria will climb up to the upper urinary tract. The last form of urinary tract is asymptomatic bacteriuria. As the word itself, it is asymptomatic. There is no symptoms, but when you do a urine culture, it would be a positive. Usually, these are more common in girls. So how will this urinary tract infection come about? The first possible cause of this urinary tract is ascending infection. Ascending, usually the bacteria from the fecal flora or from the poop or from the stool accidentally come to the have gained access to the urethral tract, or the urinary tract. Okay, so bacteria from the fecal flora will colonize the perineum, and then eventually it will go up to the urethra, go to the bladder. Some of these bacteria will even go up to the upper urinary tract and to the kidneys. Usually these are from uncircumcised boys, wherein the flora is from beneath the prepuce, which I have mentioned earlier. Another cause of urinary tract infection is from hematogenous spread. So hematogenous, as the word itself, this is from the blood supply. So the bacteria is from the blood itself, and it will gain access through the renal blood supply. So the risk factors for urinary tract includes female gender, because the anatomy of the female urethra is very close contact to the perineum, um, to the colon, nearly to the anus, right? So female genders are has increased risk of having urinary tract. Uncircumcised male, vesicoureteral reflux, which we will talk later, toilet training, avoiding dysfunction, obstructive uropathy, urethral instrumentation like inserting catheters, wiping from back to front in girls when you go to the bathroom and then you will wipe off. It should be front to back, but when you will be doing it differently, you wipe from back, from the rectum going in front, then that is another risk factor. Tight clothing, pinworm infestation, constipation, bacteria with P. fimbriae, anatomical abnormality like labial adhesions, neuropathic bladder, sexual activity, and pregnancy. So how will we able to diagnose urinary tract? Of course, we need to check for the urine. So how to do a analysis or urinalysis, how to get a urine sample. So if your child is already toilet trained, you can do the midstream urine. What is a midstream? You need to let the patient urinate a little, and then in the middle, you will collect the urine. Then that is the midstream urine. If your patient, if your child is not toilet trained still, you can do catheterized urine sample or suprapubic aspirate urine sample. So how will we read urine analysis or the urinalysis? If there are presence of nitrates and leukocyte esterase, then that would indicate positive urinary tract infection. Microscopically, if you can see hematuria or blood in the urine analysis, usually the infection is from the bladder, that is a cystitis. But if you have already seen a casts or white blood cells in the urinary sediments, that involves renal involvement. So meaning cells from the upper urinary tract is already seen in your urinalysis. So that is already, what is the renal involvement infection? That is already pyelonephritis. However, you need to instruct your patient. When you let them submit urine for analysis, make sure that urine will be tested immediately, because if the urine will sit at a room temperature for more than 30 minutes, then there will be overgrowth of contaminants. So therefore, the bacteria that you see in the urine, the the other findings of the urine analysis is not that reliable already for urinary tract infection. So this is a urinalysis of the patient. Um, let us dig into the urine analysis and let us analyze what would be the diagnosis for this one. So as I've said, if you can see white blood cells, these are pus cells that's already seen in your urine analysis. So my patient has 2039 of the white blood cells. So this would indicate urinary tract infection. So let us also see where is the infection come from? Is it in a pyelonephritis, a cystitis, or asymptomatic bacteriuria? So next, you will check for the RBC. As I've said, if there are a lot of bleeding, there is blood in the urine, most probably it is from the bladder. So my patient has RBC or red blood cells of 46. The normal range should be 0 to 11 only. And then lastly, you check for the casts. Again, if you can see cast, this involves renal involvement. That means upper urinary tract or the kidney is already invaded by the bacteria. But for this one, there is no casts involved. And then you can also see a lot of bacteria, of course, because this is an infection. So for this one, my patient has 23,099 of bacteria. Also, check for other signs of renal involvement even if you can see no casts on the upper part. Also check for the filtering system of your kidneys. Since sugar and protein is minimal and is not or no detection of this area, this means the filtering system of your patient is still intact and there is no upper urinary tract involvement. So therefore, the diagnosis of this case is cystitis. Urinary tract infection, particularly it is cystitis or the urinary bladder involvement. So another test to diagnose is to do urine culture. This is for confirmation. This is confirmatory test and for you to know what is the appropriate medications that you need to give. So how would you read urine culture if your patient is symptomatic, meaning there are symptoms like dysuria, fever, etc., etc. Then 10,000 colonies of a particular organism is already positive. But if your patient is asymptomatic and the sample is from the catheter, then a single pathogen of more than 50,000 colonies is already positive for urine culture. Or if your sample is from the bag or midstream, you just collected it from the bag or from a container, this is really not catheterized. Uh, then it should be a positive urinalysis. Your patient should be symptomatic, and the urine culture should manifest a single organism with a colony count of more than 100,000. Okay, before you will be able to diagnose that is a positive urine culture. You need to memorize the requirement on how to diagnose UTI with urine culture. Okay, it can either be this one, or can be this one, or can be this one. So this is a urine culture. Urine culture is when you will put the urine in the agar plate, and then you will place antibiotics. This is an antibiotic, antibiotic, antibiotic. So antibiotic will have a more clearing. The bigger clearing means it's more effective and more the bacteria will not grow if that antibiotic is present. So some antibiotics, that means the bacteria is resistant. The bacteria can still grow even the presence of that antibiotic. So this is a urine culture wherein it says that the bacteria involved is E. coli. So meaning that the bacteria that caused the urinary tract infection is E. coli, and it is significant because there are more than 100,000 colonies that have grown per ml. So as you can see, there are a lot of antibiotics that was being put into the agar plate, and this would help us on what is the proper treatment of your patient. For example, in this one, wherein amikacin is sensitive, meaning you can use amikacin to treat to kill the bacteria E. coli. But some of the bacteria are resistant, like ampicillin. Ampicillin meaning that the bacteria will still grow bacteria is resistant. The bacteria will still grow even if you will give a lot of ampicillin to this patient. So therefore, urine culture is of help to us if the infection is difficult to treat, for us to give the proper medication to that particular bacteria. So, other diagnostics include CBC, wherein you can see leukocytosis with predominance of neutrophils, an elevated serum ESR, or erythrocyte sedimentation rate, an elevated procalcitonin, and an elevated CRP. So, how to treat urinary tract infection? Cotrimoxazole, or the complete name is trimethoprim sulfamethoxazole, or we call it cotrimoxazole in our layman's term. This is a very good antibiotic for E. coli, but there are a lot of patients um, who succumb to what they call this one, Steven Johnson's, or severe infection to this kind of antibiotic. But theoretically, this is very good for E. coli. Nitrofurantoin is very good for Klebsiella and Enterobacter organisms. So give it at 5 to 7 milligram per kilogram per day in 24 hours, divided into 3 or 4 times a day. Amoxicillin is also a very good one at 5 milligram per kilogram per day. And if you are if you have a case of pyelonephritis, or that means the bacteria have already colonized the upper urinary tract, then give a broad spectrum antibiotics for 7 to 14 days. So oral medication includes third generation cephalosporins like cefixime. This is very good for gram-negative organisms, but not for Pseudomonas. Fluoroquinolones like ciprofloxacin and levofloxacin, these are good for Pseudomonas, but give fluoroquinolone for patients who are more than 17 years old, because there are studies that there is potential damage to some cartilage. So therefore, the growing, the height will be um, compromised. But this is not yet fully confirmed. But to just to what with a precaution, do not give fluoroquinolones for less than 17 years old, for those patients who are still growing. Okay, so IV medications, if your patient is admitted, then give ceftriaxone, cefotaxime, or ampicillin. Plus, you will give a second antibiotic, aminoglycosides like gentamicin. So imaging studies with children having febrile urinary tract infection. American Academy of Pediatrics recommend ultrasound of the kidneys, ureters, and bladder for all patients, for all children who have urinary tract infection with fever. Or you can also do VCUG, or the ureterogram. This is an ultrasound study of your kidneys. So you will inject a dye you will insert a catheter, inject a dye, and then once the dye has reached to the kidneys, you will do fluoroscopy, or or X-ray, sorry, abdominal X-ray, and then you will see if there are problems, abnormalities, atypical features, etc. So this includes for atypical features, for recurrent febrile UTI patients. Probably there are anatomical problems. So that ends the first part of my lecture. We will now proceed to the other urinary tract disorder, which includes vesicoureterial reflex. So as you can see, I have just chosen the most common renal disorders in children. So the vesicoureterial reflux is in chapter 554 of your book. This is a retrograde flow of urine from the bladder to the ureter and the kidneys, meaning rather than from kidneys going down to the urethra and be excreted, the urine will backflow, will go up. Okay, so this is because of the urethral attachment to the bladder, usually it is oblique, okay? Between the bladder mucosa and the trochoid muscle, creating a flap valve mechanism that prevents vesicoureteral reflux. So usually the urethra is like this, okay? So the urethra one, the ureter, I'm sorry. The ureter is inserted into the bladder as oblique, meaning it will have a flap. So when this bladder will contract, it will close this flap. This is the normal anatomy of your ureter as it is inserted to the bladder. But some of these babies, some of these patients, some of these children, this obliqueness is obliterated. Some it will be like this, wherein if it will contract, it will not totally obliterate, it will not totally close. So therefore, urine from the bladder will go up again. Okay, some are like this, and some, this is the worst, wherein the urine will go down and will go up again and will go down and will go up again. So that is a vesicoureteral reflux. So VUR or vesicoureteral reflux occurs when the submucosal tunnel between the mucosa and the trochoid muscle is short or absent. So it predisposes to infection of the urinary tracts or the pyelonephritis because it will transport bacteria from the bladder to the upper urinary tract. So there are classifications of your VUR. This is the International Reflux Study Classification. Grade 1, if the VUR eh, um, have just reflux into a small area of your ureter, and the ureter is non-dilated. Okay, this is grade 1. Grade 2, on the other hand, is when the VUR is into the upper collecting system. However, as you can see, there is still no dilatation of your upper collecting system and your ureter. Grade 3 is when your vesicoureteral reflux have reached the upper collecting centers, plus there is dilatation of your ureter and there is blunting of your calyceal formices. And grade 4 is when your VUR or the vesicoureteral reflux has grossly dilated the ureters. And grade 5, there is massive VUR with significant ureteral dilatation and tortuosity and loss of the papillary impression. So how would you able to diagnose your VUR? You need to do the voiding cystourethrogram. Okay, you will insert a catheter to the bladder and then you will instill a dye. So this is for the females, this is for the males. Then you will instill an iodinated contrast or radionuclide solution as dye. And then the third part, you will do an x-ray of the urinary tract during the bladder filling when the dye is already being injected, and also check if there is if the patient has already voided or the removal of your dye. Okay, so and then you will grade if um when you see the x-ray already, you grade, is this grade 1, grade 2, grade 3, grade 4, or grade 5, depending on what you have seen in the x-ray. So grades 1 and 2, there will be spontaneous resolution. You will not do anything about it. But for grade 5, it rarely resolves. So, naturally, if you have UR with infection, then it will cause renal injury later on eventually, and eventually it will scar your kidneys and damage your kidneys. So, what are the treatments? Of course, it should be surgery. So, you will correct the normal anatomic flap. So if this is the normal, so if your patient is like this, you will correct. So you change the position of its entry to the bladder so that when this will contract, it should be closed. And then while you are still on treatment, you need an antibiotic prophylaxis. Prophylaxis meaning you let your patient take in antibiotic every day, just in case there will be bacteria that's residing in the bladder, so that it will not gain access to the upper urinary tracts. So it cause the prevention of perinephritis and other VUR-related renal injury. This prophylaxis includes decrease the risk of recurrent UTI, but increase the risk of developing resistant bacteria, since you are letting the patient take in antibiotics every day. So that ends my lecture. If you have question, please type it in our Telegram group chat. I will be answering your questions anytime before the period will end. Thank you for listening. Goodbye.